Hello, I'm Guru Sonpavde. I'm the bladder cancer director at the Dana-Farber Cancer Institute in Boston, Massachusetts, USA. I wanted to talk about a few interesting projects that we have here at this ASCO meeting. Firstly, I wanted to talk about the neoadjuvant muscle-invasive bladder cancer space. As we all know, there is a lot of activity and emergence of new immunotherapy drugs, the PD-1 and PD-L1 inhibitors in the post-platinum space of metastatic urothelial carcinoma. There are trials going on looking at these drugs in the first-line space in combination with chemo. And there is interest in looking at these drugs in the neoadjuvant space, that is before radical cystectomy for muscle-invasive bladder cancer. There are a couple of studies that were presented last year that looked at atezolizumab or pembrolizumab that yielded a pathologic complete remission of around 30 to 40%, suggesting that there is some promising activity with these agents. So there are now neoadjuvant trials getting going, looking at this in a randomized fashion in big randomized trials. We have a presentation of a trial in progress here at this ASCO. It's a phase 3 trial in cisplatin eligible patients looking at neoadjuvant gemcitabine cisplatin versus gemcitabine cisplatin plus nivolumab, it's a PD-1 inhibitor. And there's a third arm that potentially will be there if the lead-in phase is completed and shows the safety of adding an IDO1 inhibitor to the gemcitabine cisplatin nivolumab. So IDO1 inhibition also enhances the immune state by inhibiting the enzyme which kind of metabolizes tryptophan to kynurenine, and therefore inhibiting this enzyme enhances the immune state and might help overcome a resistance and immune evasion mechanism of the tumors when you expose tumors to a PD-1 inhibitor. So this is a phase 3 trial that's in progress, and we await the results of this. It will take a few years, of course, to get the data. Second, I wanted to talk about a poster we have here that looked at sequencing issue in patients in the first-line setting of cisplatin ineligible metastatic urothelial carcinoma. So as we all know, in patients who are cisplatin ineligible, the first-line treatment of metastatic patients can be either a PD-1, PD-L1 inhibitor, pembrolizumab, atezolizumab. Of course, now the label has changed to only allow that in patients who are PD-L1 high in the cisplatin ineligible population. Or it is gemcitabine carboplatin, which is the older and the de facto standard in patients, and also in patients who are PD-L1 low, where we know that gemcitabine carboplatin was superior to atezolizumab or pembrolizumab. Anyway, we did a study, a retrospective study, looking at around 146 patients where these were unselected for PD-L1 high or low. This was done in an era before PD-L1 was being done routinely. And we looked at patients who were sequenced from a PD-1, PD-L1 inhibitor to gemcitabine carboplatin, or the reverse sequence, gemcitabine carboplatin followed by PD-1, PD-L1 inhibitor at progression. And the bottom line is, in the retrospective study, we found that the outcomes in terms of survival were similar, and there were some differences in terms of a treatment-free interval between the first line and the second line treatment. Obviously, that you would expect, because the chemotherapy is given for a set duration of time, about 6 cycles. Usually we stop around 6 cycles, whereas the PD-1, PD-L1 inhibitor continues until progression in most cases. So overall, though, it was reassuring to see that the outcomes were similar regardless of the sequence. Obviously, this needs to be teased out. Is there a more optimal sequence for PD-L1 high patients as opposed to PD-L1 low patients? We don't know that. It's tempting to speculate that in the PD-L1 low patients, probably gemcitabine carboplatin first makes sense, since the label is also changed. In PD-L1 low patients, gemcitabine carboplatin was superior to first-line atezo or pembro in the ongoing phase 3 trials, which have still not been reported yet fully. And also, it's tempting to speculate that PD-L1 high patients, potentially first-line PD-1, PD-L1 is quite reasonable, although we're not sure at the moment if it's better than gemcitabine carboplatin for that population. And third, I wanted to talk about a poster here where we looked at germline genetics in patients with bladder cancer. We looked at a large data set of more than 1,000 patients, was 1,038 patients who had bladder cancer and underwent germline testing, not somatic tumor, but germline testing. Now, this was not an unselected population of all comers with bladder cancer. These were patients where the physicians felt there was some risk, higher risk of some germline alteration. For example, they may have had a different cancer on top of bladder cancer in the same patient, or there may have been a family history, or the patients were young. So a somewhat selected population. But in any case, in this population, we found that 18% of patients had some pathogenic or likely pathogenic alteration of the germline. And then we zoned down into the DNA damage repair genes because this seemed to be somewhat more frequent, and there was some enrichment for the DNA damage repair gene alterations. And we found that a DDR gene was altered in approximately 11% of these patients. Again, this is not an unselected patient population. These were selected for younger or had some other cancer in the majority of cases. So now I think we do need to look at patients who were completely unselected for age or family history or second cancer, and to see if this is something that needs to be thought about more seriously. But at least at the moment, it looks like in selected patients where you consider a higher risk of germline alteration, you might want to start thinking about it, but this data still needs further validation. Thank you.